Myocardial infarction, MI, pathophysiology, focusing on myocardial oxygen supply and demand.
Hi, Mr. Jones. How are you?
I'm doing good, thank you.
Great. Now let's see. It's been about a month since you were in the hospital with the heart attack and we put in that coronary stent. How are you feeling?
Oh, I'm feeling great. I feel like a new man.
Excellent. Glad to hear that. And how are you doing with all your medicines?
You know, I can't tell you how good I feel since you put in that stent.
Good. So I assume that you're taking all your medications.
Like I said, I feel just fine.
Remember Mr. Jones? 1 month ago, he suffered a myocardial infarction, or MI. He had several risk factors for heart disease: stress, high blood pressure, high cholesterol levels, his age, and smoking. Once a myocardial infarction occurs, the goal of treatment and care is to limit the size of the infarct and restore the heart to its highest level of possible function. This involves a combination of preventative measures, including lifestyle changes, as well as medical interventions. Persons suffering a myocardial infarction are at increased mortality and morbidity risk. The American College of Cardiology Foundation, American Heart Association, recommends aggressive secondary prevention via pharmaceutical interventions to lower the risk for recurrent cardiac events and mortality. Each of the 5 evidence-based pharmaceutical interventions works to lessen the demands on the cardiovascular system in different ways. Could you answer questions or concerns Mr. Jones has about why he has been prescribed these medications and explain to him how they work and why taking them as prescribed is important in reducing his risk of future MIs? The focus of this presentation will be on reducing the heart's force or workload by emphasizing the determinants of myocardial oxygen supply and demand. Before we look at the determinants of myocardial oxygen supply and demand, to gain a better understanding of how these factors are influenced in the treatment of myocardial ischemia or infarction, let's review how blood flows during a complete cardiac cycle. There are 4 valves in the heart that function to keep blood flowing in a forward direction. The tricuspid and mitral valves are between the atria and the ventricles, and the pulmonic and aortic valves are between the ventricles and the pulmonary artery and the aorta. They prevent blood from flowing back into the ventricles at the end of each ventricular contraction. During the relaxation phase of the heart, known as diastole, the atria and the ventricles are relaxed, and blood flows from the atria to the ventricles through the tricuspid and mitral valves. As the ventricles fill with blood from the atria, they begin to stretch. The pressure inside the ventricles begins to rise, which causes the valves between the atria and the ventricles to close. As the ventricles reach their maximum stretch, the pressure inside the ventricles is able to overcome the pressure in the aorta and the pulmonic valves, and blood is ejected to the lungs as well as throughout the body. The myocardium has its own blood supply, known as the coronary circulation. Blood flow to the coronary arteries occurs primarily during diastole, the relaxation phase. So when the heart is resting, the coronary arteries are supplying oxygenated blood to the myocardium. Next, let's look at the myocardial oxygen supply. The 4 determinants include coronary arteries, coronary perfusion gradient, heart rate, and the oxygen carrying capacity of the blood. Blockages in the coronary arteries, known as atherosclerosis, cause narrowing of the vessel. This narrowing occurs most commonly in the large surface coronary arteries shown here. The narrowing may be at a specific site, or it may involve an entire length of the vessel. In either case, you can see how this type of narrowing can limit coronary blood flow to a working heart. Blood flow through the artery is influenced by how much force is needed to push the blood through the artery, combined with how much resistance must be overcome to push the blood through the arteries. The coronary perfusion gradient is the term used to describe the gradient with which the myocardium is perfused. In other words, when the heart is receiving oxygen and oxygenated blood. In order to have forward flow, you must have a high-pressure chamber draining into a low-pressure chamber. And it's the difference between the high-pressure chamber and the low-pressure chamber that creates the pressure gradient. When we consider the perfusion gradient of the myocardium, the chambers are the aorta, which is a high pressure, and the myocardium, or the left ventricle, which should be a low pressure. Therefore, the perfusion gradient will be aortic pressure minus left ventricular pressure. During systole, when the ventricles are contracting, blood flows from the ventricles to the aorta and then to the coronary arteries and myocardium. Can you see the problem with this diagram? The flow in this diagram is going from one high-pressure system to another because during systole, the ventricles represent a high-pressure chamber when they are contracting. So both the left ventricle and the aorta are both high-pressure chambers. Let's say that the pressure in the aorta is 80 and the pressure in the left ventricle is also 80. 80 minus 80 equals 0. So we have a low coronary perfusion gradient. And with a low coronary perfusion gradient, perfusion to the myocardium is also low. During systole, the ventricle is contracting so forcefully that it essentially compresses the coronary arteries from the inside out, which prevents blood flow to the myocardium. However, during diastole, the left ventricle is at rest, so pressure inside the left ventricle is low. We now have blood flow going from the high-pressure chamber of the aorta to the low-chambered coronary arteries and myocardium. Let's say the pressure in the aorta is still 80, but the pressure in the left ventricle is now 10. So 80 minus 10 is 70. We now have a high coronary perfusion gradient, so we have blood flowing to the myocardium. The third determinant we'll discuss is heart rate. Understanding how heart rate affects the myocardium oxygen supply relates to the fact that a faster heart rate decreases the amount of time that the ventricle has to completely fill. It decreases the time that the ventricle spends in diastole. And remember, blood flows to the myocardium during diastole. So therefore, the less diastolic time you have, the less myocardial perfusion you will get. The normal resting heart rate is between 60 and 80 beats per minute and is controlled by the pacemaker activity of the sinoatrial node, which is located in the right atrium. But other neurohumoral factors influence the heart rate as well. If left unmodified by these factors, the spontaneous heart rate would be between 100 to 115 beats per minute. However, in a normal resting heart, there is a significant parasympathetic vagal tone on the SA node, so that the resting heart rate is really between about 60 and 80 beats per minute. For the heart rate to increase above the intrinsic rate, there is both a withdrawal of this vagal tone and an activation of the sympathetic nerves that innervate the SA node. This reciprocal change in sympathetic and parasympathetic activity permits the heart rate to increase during exercise, for example. Circulating hormones like epinephrine bind to special receptors called beta-1 adrenal receptors located on the cardiac cells, including the SA node. The fourth and last determinant of myocardial oxygen supply is the oxygen carrying capacity of the blood, which is really referring to the hemoglobin level of the blood, because oxygen is carried to the heart and to all tissue in the body, for that matter, by hemoglobin. Quite simply, the more hemoglobin there is to carry oxygen, the more oxygen there will be to nourish the myocardium. Ischemia occurs when the supply of oxygen is less than the demand for oxygen. Let's talk next about the determinants of myocardial oxygen demand, which are heart rate and ventricular wall tension. It's easier to understand how heart rate influences myocardial oxygen demand because essentially each ventricular contraction consumes oxygen. A faster heart rate can lead to myocardial ischemia because you get both an increased oxygen demand and a decreased oxygen supply. Ventricular wall tension is the indirect force acting on the myocardial fibers, trying to pull them apart, and the energy that's expended in trying to oppose that force. Ventricular wall tension is directly proportional to the pressure in the left ventricle just before it contracts, and it's inversely proportional to the ventricle wall thickness because the force is spread over a greater muscle mass. Essentially, increasing wall tension increases myocardial oxygen demand. In the normal heart, the oxygen requirements of the myocardium are continuously matched by the coronary arterial supply. Even during vigorous exercise, when the metabolic needs of the heart increase, so does delivery of oxygen to the myocardial cells, so that the balance is maintained. Now that you have an understanding of the key determinants of myocardial oxygen supply and demand in a normal person, you can better understand how they are altered by the presence of atherosclerotic coronary artery disease. Chronic discrepancies in myocardial oxygen supply and demand increase the risk for myocardial ischemia, which can lead to myocardial infarction or subsequent MIs for a patient surviving their first cardiac event. Please proceed to the next video in this series titled Treatment of Myocardial Infarction, Beta Blockers.